So psychiatric nursing. Psychiatric nursing basically is a branch of nursing, okay, that cares for people with mental health problems to improve well-being, okay, to prevent relapse and also to support recovery. Okay, so when we say psychiatric nursing, it's basically that aspect or that branch of nursing that cares for people with mental health conditions, people with mental health problems. And the whole focus is to improve their well-being, prevent relapse, and also to support their recovery. Okay, in fact, this branch of nursing is important because it gives complete care. Okay, one thing about psychiatric nursing is that if you come to read the general nursing aspect and curative care, you realize that sometimes we neglect certain aspects of care like spiritual care and psychological care. But for psychiatry, with nursing, our whole focus is what we call holistic or comprehensive care. Okay, but usually some aspects of the holistic care is neglected when you come to curative aspects. Okay, but with psychiatric nursing, in handling or managing psychiatric condition, most of the time you have to inculcate all the disciplines. Okay, and so this branch or this field of nursing actually focus on giving complete care. Okay, they also help to detect and manage conditions very early, reduces stigma, improves coping, and also supports families and communities. Now, the scope of psychiatric nursing. Now, for psychiatric nursing, one of their scope is therapeutic communication, counseling, administering medications, crisis intervention and rehabilitation, psychoeducation, community mental health services, and research and policy advocacy. Okay, now there are times that they can ask you those kind of and I questions, questioning you on the scope of a psychiatric nurse. When we say a scope is like areas of work where they are involved in, or more like their domain of work. Okay, so for example, if you come to the scope of work of a general nurse, administration of medications, education of patients, preparing patients for surgery, post-operative care, all those things are scope of a general nurse. When we say scope of a psychiatric nurse or scope of psychiatric nursing, we are looking at their domain of work, areas where they work or areas where they practice. That is what we call scope of psychiatric nursing. Okay, and it is something that they can ask you. So psychiatric nursing, one of the areas they function a lot is therapeutic communication. If you are not good with therapeutic communication, in fact, you can't be a good psychiatric nurse, because psychiatric nurses, they deal with people with mental health problems, and so communication becomes very relevant. Okay, counseling. If your counseling skills is not so good, you may not be able to cope so well in psychiatric space. Okay, they also administer medications, and I believe many of you have had the opportunity to practice in psychiatric facilities. They administer medications. It's just like we are the curative and sometimes even at the preventive part, they administer medications. Psychiatric nurses to do that. Crisis interventions, okay, rehabilitation, care, okay, psychoeducation, community and mental health services, and research and policy advocacy. These are all scope of work of psychiatric nurses. Now, we are going to now begin psychiatric nursing proper. We will begin by looking at causes of psychiatric conditions in general. Okay, so we are going to look at the causes of psychiatric conditions in general. Now, usually psychiatric conditions, we can classify them into three. Keep it. The causes of psychiatric conditions, we can classify them into three. Okay, now the three classifications, we have biological causes of psychiatric conditions, we have psychological causes of psychiatric conditions, and we have social or environmental causes of psychiatric conditions. Okay, so we have biological causes of psychiatric conditions, we have psychological causes of psychiatric conditions, and we have social or environmental causes of psychiatric conditions. Now, what are biological causes of psychiatric conditions? If they ask you in exam, so they can give you a scenario or they can give you a question in a simple context. Okay, then they are requesting for biological for you to identify, because sometimes they can give you a question, then they will throw a question to you requesting for a specific cause, but they will be specific, either psychological, either biological. You have to be very careful, because sometimes usually those options, all of them will be correct. So you have to be very clear to know. For example, they can give you a question like depression. Okay, depression have biological causes. For example, someone can be depressed, and it may be as a result of a problem with neurotransmitter imbalance. Do you get it? But then depression can also be as a result of even poverty or family conflict, or it could even be as a result any other thing at all. You get it? So you always have to be mindful of those line of questioning. Okay, so the biological causes, we have genetic predisposition. For example, example like schizophrenia, bipolar disorders. Okay, we have people who they come from a certain bloodline where these conditions are very prevalent, and therefore they tend to be at increased rates of also suffering that condition. Okay, now neurotransmitter imbalance also falls under biological cause. We have brain injury or dementia. Okay, if someone gets involved in an accident or an injury, and or an accident or a trauma, and suffers a brain injury, that person is at risk of psychiatric condition or a mental health problem. Is that okay? For example, like Alzheimer's disease, someone who has suffered a brain injury is at risk of getting Alzheimer's disease. Okay, infections. Okay, there are so many infections that can affect the nervous system, and at a point in time, if care is not taken with respect to the management, it can lead to psychiatric conditions like syphilis. Is that okay? Syphilis can affect the nervous system, and we have what we call neurosyphilis, which can lead to psychosis. Okay, so conditions like genetic predisposition, neurotransmitter imbalance, brain injury, or dementia, infections, these are all biological causes. Is that okay? That is what we call biological cause of a psychiatric condition. So there are so many psychiatric conditions that the cause can be biological in nature. Okay. Then we have the psychological causes. A practical example of a psychological cause is childhood trauma or childhood abuse. Okay, childhood trauma or childhood abuse. Someone can be raped. A child can be raped, and it can affect that child psychologically. Okay, yes. So psychological causes are also one of the main causes of psychiatric conditions. Okay, we can have poor coping mechanisms. Okay, poor coping mechanisms. We find ourselves in a society where there are times that something may worry you, but that thing may not hit another person in any way. Okay, you may be going through something. Have you not observed that sometimes, even in school, let me use school as a practical example, we can write exams. Someone can get D, and the person will be jubilating as if the person have even topped the class. And someone will get B+, and the person will be depressed. Yes, so, and it's all about coping mechanisms. How we all cope with situations differently. Okay, so a situation that may cause someone to be depressed, another person may be going through that same situation, and the person would be the best version of himself or herself. Okay, so it's just about our coping mechanisms. Some people have very good coping mechanisms. Okay, and because of that, and all that can influence psychiatric condition. There are so many people at the psychiatric health facilities. If you go there and they tell you the causes or what led to their conditions, you smile, because probably you might have even gone through worse form of what they are going through. Okay, so it's about coping mechanisms. Okay, some people can cope with situations very well. Other people cannot cope with situations. So coping mechanisms also play a role or contribute to psychiatric conditions. We have maladaptive personality traits. Some people are not very good at all when it comes to, in fact, those personality traits, they are not very good when it comes to adapting to situations. And mostly, those people with antisocial personality disorder, they are not very good with adapting to new environment or adapting to new situations. All these things are psychological in nature. Okay, so when we say psychological causes of psychiatric conditions, we are looking at key elements like childhood trauma, childhood abuse, poor coping mechanisms. Okay, because poor coping mechanisms can even be linked to conditions, psychiatric conditions like anxiety and depression. Okay, poor coping mechanisms can also be linked to depression. Okay, we can have maladaptive personality traits. Okay, good. Now let's look at the next cause of psychiatric conditions. We have social or environmental causes. The social or environmental causes. Social causes like, we have social causes like poverty or unemployment. Okay, someone can be unemployed for a long time and end up getting depressed. Do you get it? Yes, unemployment. Okay, poverty. Okay, we even have family conflict or broken relationships. Those broken hearts and those things. People experience broken hearts and they tend to suffer depression. They tend to become anxious and all that. Okay, so all those things also comes under social causes. Family conflict, broken relationships. Okay, we even have peer pressure. Peer pressure, for example, peer pressure can cause someone to go and abuse a substance or a drug or even an alcohol and ends up suffering from a psychiatric condition. Peer pressure. Is that okay? Peer pressure. Okay. We can have cultural or religious stresses. Sometimes people find themselves in certain cultural environments or space where they may be stressed by their culture, sometimes to do certain things which may be against their values or which may be against their will. Okay, and that can go a long way to affect people psychologically. Is that okay? So cultural or religious stresses. Okay, good. All that can cause to. Now let's look at the classification of the causes. Classification of the causes. Okay, with the classification of the causes, we have predisposing factors. Okay, and then we have precipitating factors. When we say predisposing factors, in terms of classification, predisposing factors, we can have family history. Okay, so when we say a predisposing factor, they are more like conditions or situations that can increase your chances, okay, of getting a condition. So, for example, if you belong to a bloodline where there have been a lot of recorded cases, or a family line where there have been recorded cases of schizophrenia, your chances of getting schizophrenia becomes very high. Okay, now we have precipitating factors. The precipitating factors, usually predisposing factors, are more related to family history or genetic predisposition. Okay, but the precipitating factors are more like conditions or situations, or it could be a lifestyle. Okay, so when we say a precipitating factor, it could be a lifestyle that you are involved in. So, for example, drug abuse, okay, or substance abuse. Okay, so if you are abusing a substance, you are involved in stress. So, for example, maybe you do a lot of vigorous activity. You are involved in so many stressful activities. Do you get it? Good. It will be a precipitating factor. Precipitating factor is like a condition that can increase your chances. And mostly precipitating factors, we can do something about precipitating factors. So, for example, if you are abusing a substance like a drug, and that is triggering maybe depression or any other mental, we can do something about precipitating factors. For example, if you are involved in stressful activities, we can do something about the stress. We can manage it. Do you get it? But usually predisposing factors are more like factors that you can't, control. Predisposing factors like genetic predisposition or family history. Okay, we can have perpetuating factors. Perpetuating factors include stigma, non-adherence to treatment, and we have protective factors. When we say protective factors, we have strong social support. Okay, so in psychiatry, when we say protective factors, Protective factors are strong social support. If someone is depressed and the person have a strong social support, the person can recover easily, as compared to someone who is stressed or depressed, who is not having a strong social support. Okay, and some people too are very resilient. They never give up. They can easily recover. They are very strong emotionally. So such a person, if the person should even be hit by a broken relationship, they are very resilient. They can easily recover from either a stress, either a depression, or either any psychiatric condition. Okay, and another protective factor is access to health care. You know, if someone is about to develop a certain mental problem, but then there is a good access to health care, that person is more likely, to recover as compared to someone who finds himself or herself in an environment where there is no access or lack of access to health care. Okay, so generally speaking, these are the classifications, or these are the causes of psychiatric conditions. So biological causes, psychological causes, social or environmental causes. Then we have the classification of the causes. So when we say biological causes, like neurotransmitter imbalance. Okay, so the examiner can ask you that, maybe a patient is suffering from, a nurse conducted assessments, find out the patient is suffering from a condition like depression. Okay, which of the following, or one of the following, is a psychological cause of depression? Then they will bring neurotransmitter imbalance, poor coping mechanisms. Then they will bring unemployment. Then quickly, once they are talking about psychological causes, your answer would be poor coping mechanisms. If the question was requiring for biological causes, then you'll be looking at brain injury, you'll be looking at neurotransmitter imbalance, genetic predisposition. Is that okay? Good. So basically, these are the causes of psychiatric conditions. Now, let's begin with our first psychiatric condition, mood disorders. Mood disorders. Now, when we say mood disorders are basically mental health conditions where a person's emotional state is disturbed for a prolonged period. So when we say a mood disorder is a situation where an individual's emotional state is disturbed for a prolonged period. And usually it affects their daily functioning, or it affects their daily behavior. Okay, so in mood disorders, someone's emotions are affected, and it can affect how they behave. That is a mood disorder. Okay, now, in fact, mood disorders may be caused by a combination of genetic factors. It can be as a result of a problem with the brain chemistry imbalance, like neurotransmitter imbalance. Okay, specific neurotransmitters that are related to mood disorders, we have serotonin and dopamine. Serotonin and dopamine, these neurotransmitters, they can influence your mood. Okay, and then stressful life events, chronic medical illness, or substance abuse. Now let's look at major types of mood disorders. The major types of mood disorders, we have depression, we have mania, and we have bipolar disorder. When we say depression is a situation where you are persistently sad, sadness. You are hopeless, when you are feeling hopeless, or you lose interest in activity. Okay, so when we say someone is depressed, the person is sad, you are feeling sad. Okay, you are feeling hopeless. And then depressed individuals also tend to lose interest in activities that previously they found joy in. So if the person previously liked listening to music or watching movies or maybe going on an outing, depressed individual may not find joy in doing those things again. Okay, we have mania. When we say mania is an abnormally elated or irritable mood over activity or poor judgment. Mania is more like the opposite of depression. So mania over here, the person is overly elated, more like euphoria. Okay, so it's like over excitement. Someone can be excited so much that it becomes abnormal. It's also a psychiatric condition. That is mania. Okay, yes, there are times that, for example, let me give you a practical example. You can go and check your licensing exams results and find out that you pass all your courses. If you don't take care, you can walk with your friends from your school to a long distance without even realizing. You get it? Yes. Mania, overexcitement. You get overexcitement, abnormally elated or irritable mood. And usually those people become overactive, and sometimes it affects their judgment. Okay. Then we have bipolar disorder. Bipolar disorder is when someone or a patient is alternating. So at one point in time, the person is depressed. At another time, the person is in a manic episode. So the person is alternating between two episodes, mania and then depression. So at a point in time, the person is in a manic episode, and at another time, the person is in a depressive episode. That is the bipolar disorder. So bipolar disorder is not fixed. At one point, the person is manic. At another time, the person is depressed. That is a bipolar disorder. Okay, that is a bipolar disorder. Now, let's look at the signs and symptoms of these conditions. So let's begin with depression. Now, the cardinal sign of depression is persistent sadness, loss of interest in pleasurable activities. Now, see, this word, anhedonia, when we say anhedonia, it means loss of interest in pleasurable activity. It's one of the cardinal signs of depression. If someone is depressed, they lose interest in activities that previously they seem to have pleasure in. And that is what we call anhedonia. Okay, and these two are the cardinal signs of depression: persistent sadness and loss of interest or loss of pleasure. Okay, and the term we call it anhedonia. So anytime you hear anhedonia is when it's a medical term that represents when someone loses interest or pleasure. So things that you do, in fact, that same person used to do and was found pleasure in those activities. Now the person will do them, and the person is even not interested anymore. Okay, and that is what we call anhedonia. We can also have other signs like fatigue, poor concentration. If someone is depressed, they are not able to concentrate. Okay, depression can even affect your sleep and appetite. There can be sleep and appetite changes. Now, listen, you see over here, we didn't use loss of appetite, or we didn't say the person will gain appetite. It can fluctuate. We have people who gain appetite a lot when they are depressed, and we have people who lose appetite when they are depressed. We have people that when they are depressed, they sleep, and we have people that when they are depressed, they are not able to sleep. So that one is not fixed. Okay, so all you can think of is that there will be sleep and appetite changes. Okay, because there are people who are able to sleep better when they are depressed. And we have people who will not sleep at all when they are depressed. And we have people who will not be able to eat when they are depressed. We have people who will be able to eat better when they are depressed. Okay, depressed individuals may also have suicidal thoughts. And then they may have low self-worth. Okay, so these are the cardinal signs. So the cardinal sign of depression, we have persistent sadness, loss of interest or pleasure, which is anhedonia. But then we can have other signs like fatigue, because usually these patients may not eat. Okay, they may have problems eating because of the loss of appetite. That is, if the patient is experiencing a loss of appetite, that would render them becoming fatigued, generally very weak and tired. Okay, there can be poor concentration, suicidal thoughts, and low self-worth. Now let's come to mania. So mania, the cardinal signs of mania: elevated or irritable mood. Now we can have other signs like decreased need for sleep. Usually if people are so elated, they are so happy. Okay, most of the time, if people are so elevated, euphoric, so excited, most of the time they don't even feel like sleeping. Okay, so for those of you who are thinking that, oh, after the exams, I'll sleep for days, you finish the exams, it will go so well. Because of the euphoria or the joy or happiness, you may not be able to sleep properly. Okay, so decreased need for sleep. Rapid speech. If someone writes exams, the exams go well. Sometimes you realize the way those people can talk, they can talk and give the marking scheme left and right. They'll be talking. That is what we call rapid speech. Okay, so for example, let's say someone, you've given birth, you are happy, everything went well. Those people, they can talk and talk and talk. It's because of the what? Euphoria. It's because of the elevated mood. Because so they are trying to express themselves. They are trying to bring out the joy in them. You get it? And that is what we call rapid speech. It's a character or a sign of people who have mania. Is that okay? Now we can have racing thoughts, impulsivity. We can have grandiosity and poor judgment. When we say impulsivity, okay, those people are usually they always want to be seen. Their impulses are always very high. Okay, they always want to be seen. Okay, because you see, most of the time, if for example, imagine someone who have won a lottery, and that's why sometimes someone will win a lottery or will win a deal, they will go somewhere, go and spray money. They have high impulse. They want to be seen wherever they are. Okay, and sometimes some of them become grandiose. Do you get it? And they will become grandiose. Oh, I'll buy the whole Ghana. Grandiosity is when people are making statements that more like exaggerative statements. I'll buy the whole Ghana. I'll become the president of Ghana. You get it? I'll be the best student in the world. You get those kind of statements. Okay? So that is what we mean by grandiosity. Okay, and it's one of the signs of mania. Okay, they usually also tend to have poor judgment. Okay, someone can be so euphoric to the point that they may not be able to judge clearly between what is even bad. Okay, you can have someone who does not drink or does not take alcohol, but because the person probably maybe the person passed an interview, the person is so happy to the point that the person may not even notice when he or she took an alcohol, especially when maybe the person is among friends. The euphoria alone can make you take a decision that later, when you come to your senses, you'll be shocked. So usually that's why we say people who are in manic episode, they have poor judgment. Okay, they have poor judgment. So these are the signs of mania: elevated or irritable mood, decreased need for sleep, rapid speech, racing thoughts, impulsivity, grandiosity, poor judgment. Okay, then when we say bipolar disorder, for bipolar disorders, the signs and symptoms depend on the episode. You know, bipolar, you can have an episode where the person is manic and an episode where the person is depressed. So the sign of the bipolar disorder would depend on the episode the patient is in. So if the patient is a bipolar patient, but then the patient is in a depressive episode, that patient is going to be sad, that patient is going to feel hopeless, that patient is going to lose interest. But however, if the patient is in the manic episode, that patient will be elated, irritable, that patient is going to have decreased need for sleep, rapid speech, racing thoughts, impulsivity, grandiosity, and poor judgment. So for bipolar disorder, the sign or symptom may alternate depending on which episode the patient is in. Is that okay? Good. Now, as a nurse, when you are caring for a patient with mood disorders, you pay attention to the pharmacological management. And usually with regards to the pharmacological management, we give the patient Yes?
Sir, please, the manic, is it all about happiness?
Come again?
The manic, is it all about happiness? Because you said the person is happy and irritated mood.
No. It's not even about happiness. It's like elation. When we say elation is more like an exaggerated, someone be exaggerating activity. Okay, so not only about happiness. I'm using the happiness to help you understand. But then the best word to use is euphoria. Okay, if you say happiness, happiness may be normal, but then someone may be happy and may do certain things that are abnormal. That is when mania comes in. Okay, and that's why the best word we use over here is elevated mood. Elevated. Okay, you can also use euphoria. Is that okay? Elevated mood. Okay, so you realize someone can win a lottery, the person will be happy. It's normal. But someone can be so happy to the point that they may do things that are abnormal. Okay, and that is what we refer to as mania. Elated, and those people are very aggressive. They can be very aggressive. It's like they want to be seen everywhere. Is that okay? They want to show off. And that's how the impulsivity comes in, grandiosity. That is how all those things come in. Okay, and they may end up even doing things that they don't. So not necessarily, don't limit it to happiness, because happiness is not something that is abnormal. Okay, but the behavior, the abnormal behavior that may be attached to a situation where the person is overly excited, that is what we mean by mania. Is that okay? So it's not just about happiness. Is that okay? All right, that is fine. Now, the pharmacological management. Now, for patients with depression, we usually give them antidepressants. Okay, so the antidepressants, we can have selective serotonin reuptake inhibitors. We can have selective norepinephrine reuptake inhibitors, and then we can have tricyclic antidepressants. Okay, these are the range of antidepressants that we can give to patients with depression. Then for patients with mania or bipolar, we can give the mood stabilizers. Now, the common mood stabilizer, this lithium carbonate, this medication, pay attention to it very well. It's a mood stabilizer. In fact, mood stabilizers, we can give it to patients even with depression. Okay, pay attention to this medication, mood stabilizers. Okay, good. And sometimes, you can have patients with depression, mania, or even depression who may experience psychotic symptoms. And if that happens, we give them antipsychotics. Okay, if that happens, we give the patients antipsychotics. Okay, now we can also do psychotherapy like cognitive behavioral therapy, the CBT. Don't worry, we will do CBT along the line. All the psychotherapies, I'll walk you through all of them. We can also do supportive counseling. Okay, good. So for example, if someone is depressed because of, let's say, poverty or unemployment, you can do counseling, supportive counseling. Okay, other options, sometimes in very severe cases, they can do electroconvulsive therapy for severe or resistant cases. That is followed with a lot of complications. They can do electroconvulsive therapy, ECT. Now, as a nurse, okay, you have to build therapeutic nurse-patient relationship. If you are nursing a patient with depression, with mania, or with bipolar, build a therapeutic nurse-patient relationship. You have to ensure safety. Okay, because sometimes, you remember we mentioned that patients with depression, they usually have suicidal thoughts. So sometimes you have to ensure safety. You have to do your physical assessment very well to identify patients. Do your assessment very well to identify patients who are suicide risk. And patients, the impulsivity. These patients may even do things that may even affect other people. So you have to do your assessment very well so that there will be safety. Okay. You also have to promote adherence to medications. Make sure patients adhere to their treatments or adhere to their medications. Okay. You have to encourage regular sleep, the intake of balanced diet, and you also have to encourage physical activity. Lastly, you have to provide education to patients or family about conditions, relapse prevention, and then community support resources. Okay, so these are the treatment measures that you can rely on when you are nursing patients with mood disorders. Now, the next class of psychiatric or the next psychiatric condition we will talk about is the eating disorders. The eating disorders. Now, when we say eating disorders are more like serious mental conditions that are marked by disturbed eating behaviors, distorted body image, and harmful effects on physical and psychological health. Okay, now we have about 3 types of eating disorders. We have anorexia nervosa. These are the common ones they usually ask in the exams. Anorexia nervosa, we have bulimia nervosa, and we have binge eating disorder. Anorexia nervosa, bulimia nervosa, and we have binge eating disorder. Anorexia nervosa. When we say anorexia nervosa, we are looking at severe restriction of food intake, intense fear. This condition is characterized by severe restriction of food intake, intense fear of weight gain. If an individual is having anorexia nervosa, usually they will restrict themselves of eating. And most of the time, their focus is to lose weight. They want to lose weight. Okay, their focus is to, I think I kept in the diagram over here, or I took it out. Okay, I think I took it out. Okay, usually their focus is to lose weight. Is that okay? So they tend to restrict themselves from taking in food. That is anorexia nervosa. Anorexia nervosa. Severe restriction of food intake. And mostly what is causing this restriction of food intake is that they fear to gain weight. They fear to gain weight. Now, bulimia nervosa. With bulimia nervosa, what happens is there is recurrent binge eating. So the patient tends to eat a lot. Then after eating, it is followed by compensatory behaviors. Okay, so the patient eats a lot. The patient will eat. Then quickly, that activity is followed by binge compensatory behaviors, like the person trying to induce vomiting, the person trying to take laxative, or the person trying to over-exercise. So the person can eat a lot. The person can be someone who will be eaten. But at the same time or along the line or alongside that behavior, the person is doing or undertaking activities, consistent activity to lose weight. That one is what we call bulimia nervosa. The difference is that over here, the person is not taking the food at all, and the focus is to lose weight. But over here, the person eats. Then the person take an action to lose the energy or to lose the food the person has eaten. That is what we call bulimia nervosa. So recurrent binge eating followed by compensatory behaviors like vomiting. It could be intake of laxatives, okay, or over-exercise. That one is bulimia nervosa. So anytime you hear bulimia nervosa, like someone who eats, then right after eating, the person even tries to induce vomiting. In such a situation, we are talking about bulimia nervosa. We can also have binge eating disorders. We have people who eat a lot. They are not going to, purge the food. They wouldn't purge the food. They wouldn't take any action to lose the food that they've eaten, or they will not go and do any exercise. No. Those one, we call it binge eating disorder. It's also a disorder, binge eating disorder. Now, let's look at the signs and symptoms. With anorexia nervosa, the cardinal sign is that there is restrictive eating. The person don't eat. The individual do not eat. And you see, if someone is not eating, the person will obviously lose weight. So they tend to have very low body weight. Now, we can have other signs like amenorrhea. We can have lanigo hair. We can have fatigue. We can have intolerance to cold. And we can have distorted body image. Okay, so these are all cardinal key signs of anorexia nervosa: restrictive eating, very low body weight, amenorrhea, lanugo hair, fatigue, intolerance to cold, and distorted body image. Distorted body image. Okay, good. And that is anorexia nervosa. So over here, the patients do not eat at all, restrictive eating. So anorexia nervosa is not like the person who eats and try to take in an action to lose weight. The person don't eat at all. The person do not eat at all, restrictive eating. Okay, and they tend to have very low body weight because they are not eating, and because of that, they can suffer. If you say they can suffer amenorrhea, okay, lanigo hair, fatigue, intolerance to cold, and distorted body image. Bulimia nervosa, recurrent binge eating with compensatory purging. So here they eat a lot, but then right after eating, they try to take in an action to lose the weight. That's the problem over here. Please know the difference between bulimia nervosa and anorexia. Anorexia nervosa, they don't eat at all. And the focus is they want to lose weight. But the bulimia nervosa, they eat. Then right after eating or whilst eating, they are also taking in measures or taking measures to lose the food they've eaten. So, okay, so it can be followed by behaviors like self-induced vomiting, laxative, or overexercise. Okay, good. And someone with bulimia nervosa may have normal body weight, or the person may be overweight. You get, the person can have a normal body weight, or the person can be overweight. Unlike anorexia nervosa, where the patient will lose weight. Okay, so if they give you a question, they tell you the patient is having distorted body image, amenorrhea, very low body weight. These are all signs of anorexia nervosa. If they say the patient eats a lot, binge eating, with compensatory purging, or the patient eats, then the patient do self-induced vomiting. Okay, that one, then they are talking about bulimia nervosa. Okay, patients with bulimia nervosa can even have or suffer electrolyte imbalances. Okay, shame and then guilt. So they can eat a lot and become shameful and guilty. Then right after that, then they try to take in actions to lose weight, like over exercising or even taking in laxatives or self-induced vomiting. Now, the binge eating disorders, just as we explained earlier, these are recurrent binge episodes without purging. It's not like bulimia nervosa where they eat a lot and then they purge. No, here they don't purge, they just eat a lot. So mostly here, the patient is going to be obese. So when we say patient is having a binge eating disorder, that patient is definitely going to be obese. Okay? And sometimes they are going to experience distress from distress after eating. They would experience hypertension. And these patients are at risk of diabetes. Okay, they are at risk of diabetes. Now, remember that sometimes, some of these problems, they can even be as a result of depression. For example, like anorexia nervosa. Do you know anorexia nervosa? It can be as a result of depression. So someone can be depressed. Okay, good. Someone can be depressed and will not be eating. Okay, it can be as a result of depression. With a pharmacological management, sometimes there are times that we give the patient antidepressants, like the fluoxetine. Okay, antidepressants. We can give appetite stabilizers or mood stabilizers. Okay, appetite stabilizers. I mentioned that anytime you hear mood stabilizers, think about this medication, lithium. There is a past question on it. Lithium is one of the psychiatric medications you should expect so much in the general paper. Lithium. And we usually give it to patients with mood disorders. We can also give it to patients with eating disorders. Okay, appetite stabilizers or mood stabilizers. Now, the psychotherapy, they can do cognitive behavioral therapy. They can do family-based therapy and nutritional counseling. Okay, so family-based therapy and nutritional counseling. Now, with medical care, you have to monitor the weight of the patient. You have to correct dehydration, electrolyte imbalance, and you have to treat complications. Okay, so you monitor weight, you correct dehydration, electrolyte imbalance, and you treat complications. Now, nursing care and nursing interventions. So as a nurse, if you are nursing these patients, focus on establish trust and therapeutic relationship. You have to monitor the vital signs of the patients, the weights, and the laboratory values, especially the electrolyte balance. Okay, you supervise meals to prevent purging. So you supervise the patient's meal intake. Is that okay? Now, encourage balanced diet and gradual weight restoration. Provide, especially a patient with anorexia nervosa, not eating at all, severe restriction of food intake. No, you have to encourage the patient to eat. Okay, you encourage balanced diet and gradual weight restoration, especially when you are nursing a patient with anorexia nervosa. You have to also provide emotional support, education, and involve family in the care. Now, you also have to prevent relapse with long-term follow-up and support groups. Okay, prevent relapse with long-term follow-up and support groups. Okay, that is fine. That is fine. Okay, let's look at the next
Hello,
condition.
sir.
Yes, please.
Sir, sir,
Yes.
please, can you hear me?
Yes, I can hear you.
Okay. Sir, please, I saw a question on anorexia nervosa, and the
Okay.
question was like, patients with anorexia nervosa tends to have parents who are overprotective. Like
Okay.
the overprotective was the answer, but
Okay.
I don't really get it.
So can you come again with the question?
I said the question was like patients with anorexia nervosa tends to have parents who are, and the answer was overprotective.
Okay. And that was the best option we did then.
Yes, please.
Okay, so anyway, if that was the best option in the context of the question that was asked, in fact, if you are not giving us the other options for us also to try our heads on the correct answer, in having in mind that sometimes some answers in some questions may be provisional and may not be the correct answer. But fine, all that aside, there is also a rationale that can be linked to overprotective parents, because you see, overprotectiveness can stress children. Okay, and it can affect. You remember when we started the courses of psychiatric conditions, we were looking at, when we started the courses of psychiatric conditions, we look at the social and environmental courses. Okay, good. We have even psychological courses. Is that okay? Under the psychological, there are so many things, like even stress alone can lead to so many psychological conditions, including eating disorders. Okay, so overprotective children can sometimes affect it may even render the person to become stressful. Is that okay? And apart from that, overprotectiveness may not let people have that kind of social integration. Okay, because you see, sometimes look at this psychiatric condition as one of the causes. Look, antisocial personality disorder. It can affect how people adapt. Okay, antisocial personality disorder is one of the serious causes of psychiatric conditions. Okay, so if your parents are overprotected, it can, you can develop that trait, maladaptive personality traits. Okay, maladaptive personality traits, and it can be a risk factor for so many psychiatric conditions, including eating disorders, not only relating to even anorexia nervosa. It can be a risk factor for so many psychological conditions. Is that okay? So there is a point in there Okay, there is a rational basis in there that you can link to. You can link to overprotective parents. Okay, because if your parents are overprotective, you may end up becoming antisocial. Do you get it? And you may even end up having issues with, because if you are not really exposed, sometimes you may not be able to make good decisions. Your judgment may be poor, because probably if this person is exposed to the social environment or other cultures, the person may be able to, because probably the parents are not so concerned about that behavior of the child. Because you see, it's not all parents that are very objective when it comes to the behaviors, even the growth, the development of their children. Some don't really care, probably because of maybe their work, or also because of their own stresses and all that. Okay, and that can be a serious risk factor for unrest. So there is a rational basis in there. Okay, good. Let's look at delirium. Delirium. Now, when we say delirium is an acute fluctuating disturbance of consciousness, attention, and cognition that develops over a short period. Okay, usually it could be hours to days, and mostly it is reversible if the underlying cause is treated. Okay, and that is what we call delirium. In fact, this condition, they usually ask questions on it in the exams. Okay, so in delirium, there is fluctuating disturbance in someone's consciousness. Okay, good. So there is fluctuating disturbance in someone's attention or cognition that develops over a short period, and it is reversible. Okay, it is reversible. Okay, look at the causes. It could be as a result of infection. It could be as a result of pneumonia. It could be as a result of hypoxia. You realize that if someone experiences severe anemia, okay, if someone experiences severe anemia, okay, sometimes because of the low hemoglobin within the blood, you get the oxygen carrying capacity of the blood goes down. Those patients can experience delirium. They can become unconscious temporarily for some time. And that is what we call delirium. Delirium is a sign that we see in a lot of medical conditions, but then its basis is in psychiatry. It's psychological. Is that okay? So someone can even experience electrolyte imbalance, can have electrolyte imbalance and would experience delirium. So when we say delirium, if you are reading a question, you see delirium, we are talking about a condition where the patient can fluctuate between consciousness and unconsciousness. You see the person become conscious, later the person is unconscious. That is delirium. That episode is delirium. Okay. You can see the person is okay, and sometimes it can even happen to you when your blood sugar goes low. You can experience delirium, low blood sugar level. Okay, and that is where that is where metabolic disturbance comes in. See, hypoglycemia. Okay, that is delirium. So a sign or a situation where it's like the person becomes conscious at a point, at another time the person is unconscious. You could see the person has lost attention. At another time, the person is attentive. Okay, the person has lost, cognition. At another time, the person is very focused. Okay, that condition is what we call delirium. Delirium. Disturbance in consciousness. Disturbance in consciousness. Okay, we have about 3 types of these delirium. We have hyperactive delirium, we have hypoactive delirium, and we have mixed delirium. When we say hyperactive delirium, usually it's characterized by agitation, restlessness, and hallucinations. We can have hypoactive delirium, which is characterized by lethargy, reduced alertness, and withdrawal. We have mixed delirium, which is characterized by they usually fluctuate between hyperactive and then hypoactive delirium. Okay, now with the signs and symptoms of delirium, obviously we have disturbance in attention. disturbance in attention. We can have disturbance in awareness. Okay, and that has got to do with reduced orientation to environment. Disturbance in awareness. If someone is unconscious, usually they are not aware of the environment. Okay, we can have other symptoms like disorientation to time. You ask the person what is the time, you know very well it's morning, then the person says it's evening. Delirium. Okay, disorientation is one of the cardinal signs of this condition. Delirium, disorientation to time, disorientation to place, and disorientation to person. We can even have memory impairment. Okay, memory impairment. We can have signs like hallucinations, illusions, and paranoia. And then there can also be altered sleep-wake cycle. Now, in fact, we can even have some medications that someone can take and end up experiencing this condition. There are some medications. Okay, someone can even take someone can even become delirious because of drug toxicity, like a side effect from a medication, or as an effect from abuse of a certain medication, drug toxicity. Okay, someone can even be delirious because of alcohol withdrawal or drug withdrawal. Is that okay? And these are all things that you have to pay attention to. Okay, delirium can even be as a result of environmental factors like hospitalization, okay, sensory deprivation or overload, and then surgery. Okay, there are times that someone, because of the anesthesia that they give, someone can experience delirium because of all that. Okay, good. So that is it for delirium. Now, in terms of the treatments and then the nursing management, okay, in fact, if someone is having delirium, usually the focus is on, there is not one specific medication you can give to a patient. So you have to understand that for delirium, it's a condition that someone who is even having other medical conditions can experience it. But because it's affecting the brain, the basis is neuro. That is why we treat it under psychiatric conditions. Is that so? Someone can be having diabetes mellitus and would experience delirium, like hypoglycemia, and the person would experience delirium. The person will lose consciousness, will become disoriented to time, to place. Do you get it? To environment, to person. Do you get it? That is delirium. So we don't have one specific treatment for the condition. But then, so for example, if someone is having a certain infection, like let's say bacterial meningitis, and because of that, the person is experiencing delirium, you treat the infection, then the person will be okay. If someone is having, let's say, electrolyte imbalance, and because of the electrolyte imbalance, the person is experiencing delirium, you treat the electrolyte imbalance. If someone is having drug toxicity, and because of the drug toxicity, the person is experiencing delirium, you treat the drug toxicity. So, the treatment is based on what is causing the delirium. Okay, good. You can also do supportive care like hydration, oxygenation, and nutrition. Okay, no, good. Sometimes if the patient experiences hallucination, you remember that we mentioned that patient can experience psychotic symptoms like hallucination. If the patient experiences hallucination, then we can give low-dose antipsychotics. For example, haloperidol. Okay, haloperidol, especially when there is severe agitation. We can give the patient haloperidol, low-dose antipsychotics. We can even give the patient benzodiazepines. Okay, especially when it is due to alcohol withdrawal. We can give the patient benzodiazepines if the condition or the delirium is as a result of alcohol withdrawal. Okay, so as a nurse, if you are nursing a patient with delirium, and now listen, one of the questions that I saw on this delirium was about this. ensure safety. So as a nurse, you are nursing a patient with this condition. One of your priority, your main aim should be to ensure safety and prevent falls. Because see, these patients are so disoriented to time, place, and person. Time, place, and person. So you need to what? Ensure safety. Put in place measures to prevent falls, to prevent injury, to remove hazard. Because you see, the patient is having disturbance in attention, inability to focus. Okay, the patient have memory impairment. Is that okay? So you have to put in place measures to prevent. And this is an unconscious patient, a patient who can be unconscious that we are talking about, a patient who have problem with attention. So you have to put in place measures to prevent falls, to prevent injury, and also remove hazards. You have to provide a calm, well-lit environment to reduce sensory overload. You have to reorient patients frequently because these patients, see, the patient is disoriented. So frequently, you have to reorient the patient again. You should be monitoring the vital signs of the patient. Make sure you hydrate the patient. Make sure you review the patient's labs. And you also have to promote sleep in these patients. And it's very important that you also involve family for reassurance and then orientation. Now, let's look at another very interesting condition they always ask questions on, which is schizophrenia. Schizophrenia. Now, when we say schizophrenia is actually a psychiatric disorder involving disturbance in someone's thoughts, someone's perception, your emotions, behavior, and it impairs your daily functioning. So, for example, you see, in a typical way you can understand schizophrenia is that, okay, you are going to class, everybody have been asked to wear white. A schizophrenic person will only come with black. We've been told that every day in class, nurses, your class, we wear white. The schizophrenic person will come with black. Okay? They are always doing things differently. Is that okay? There is a disturbance in their thought pattern, their perception. They see things differently. Emotions, their behavior, okay? And impaired daily functioning. Is that okay? Now, the causes of schizophrenia, we can have genetic causes. We can have neurobiological causes. When we say neurobiological causes, we are looking at biological causes that are related to the nervous system. Okay, we can have environmental causes and psychosocial causes. Genetic. Schizophrenia, we have some people who belong to certain families where schizophrenia is very common. If you happen to come from a family like that, your chances that you get schizophrenia is usually very high. Okay, if you belong to a family where, prevalent schizophrenia is very prevalent, your chances that you can get, and that is a genetic cause. Okay, so the cause of schizophrenia is multifactorial, meaning it can be as a result of different factors. One of them is genetics. It can also be as a result of neurobiological. Okay, so someone is having dopamine imbalance or glutamate imbalance. These are all neurotransmitters. Okay, it can cause schizophrenia. Someone is having a problem with the structures in the brain. It can cause schizophrenia. We can have environmental causes like prenatal infections. Okay, prenatal infections. Prenatal infections can also be a cause of schizophrenia. Prenatal infections, malnutrition, birth complications. Okay, birth complications. These are all some of the possible causes of schizophrenia. Okay, so most of the time, a patient with schizophrenia, you realize that they have disorganized behavior. They are not really organized. Okay, disorganized. So if you are trying to compare how they behave, I'm showing you a simple way you can identify schizophrenia in a person. So if you have a group of people, how are you going to know someone is schizophrenic? You are going to see that their behavior is different. Everybody have reported to class at 7. Schizophrenia patient will come when we are about to close. And that person will come with a uniform that completely different from what everybody is wearing. And their behavior is completely disorganized. Those are all characteristics of schizophrenia. Okay. Now, with the types of schizophrenia, we can have paranoid schizophrenia. We can have disorganized schizophrenia. We can have catatonic schizophrenia. And we can have undifferentiated or residual schizophrenia. Now, let's look at the meaning. When we say paranoid schizophrenia, patients with paranoid schizophrenia, they usually experience delusions and hallucinations. So if you say a patient with schizophrenia is paranoid, that patient, as part of the signs and symptoms, the patient experiences delusions and hallucinations. That is when we say the person is paranoid. So when you hear them saying paranoid schizophrenia, it means that and hallucinations. Now, when we say disorganized schizophrenia, mostly patients with disorganized schizophrenia, they mostly have disorganized speech or disorganized behavior, and they have flat affects. They don't have emotions. So, for example, you tell the person that, oh, I lost my mother, then the person will tell you, oh, that is good news. You realize that it is abnormal. You see, if you tell someone something that is sensitive, you expect the person to show a certain kind of emotion. People with schizophrenia, they have flat affects. If you say flat affects, it's like the person don't have emotions. That is what we call flat affects. Okay, and they usually have disorganized. So if you say someone is having disorganized schizophrenia, their behavior is disorganized, and in addition to that, they have flat affects. That's the 2 points you have to know. So if you say that, okay, a patient is having disorganized schizophrenia, it means that patient is having disorganized speech. It could be the person's speech is disorganized. So for example, you raise a topic you are talking about. Then the topic, maybe you are talking about NMC exams. So the person is also talking about BECE. Or the person is now coming to talk about something that is not even about NMC. It's not even about exams. Disorganized speech and behavior. Is that okay? Their behavior is disorganized. Considering the normal pattern of how things are done in a particular society, their behavior is completely abnormal. And they have flat affects. They do not have emotions. They do not have emotions. Then we have catatonic schizophrenia. How are we going to know that a patient is having catatonic schizophrenia? Usually those patients, they have motor rigidity, they have mutism, and then they have what we call echolalia. Okay, echolalia. When we say catatonic schizophrenia, okay, patients who have catatonic schizophrenia, they usually have what we call motor rigidity. So you see, sometimes you'll be walking on the street, you see someone, the person will be standing there like statue. No movement, no talking. The person will just be standing there one place. Okay, motor rigidity. The person will be standing there stiff. One in a particular position, the person will just be standing there. Is that okay? That is what we call, all those are possible signs of catatonic schizophrenia. It's an abnormal behavior. Can you imagine, let's say we come to your class, then a patient, one of your colleagues will stand there in front of the class, one position. The person will assume a certain position, stand there. The person has not been instructed. The person will just be standing there. Okay, stiff, just standing there, motor rigidity, and then mutism. The person someone can also choose not to talk for months, which is also abnormal. Is that okay? And those are all signs of, those are all possible signs of schizophrenia, but then specifically catatonic schizophrenia. Okay, we can even have what we call echolalia. Look at this word, echolalia. You know, you can have someone who can be repeating a certain word for a long time. The person can be repeating one statement The person can be repeating it for almost 1 week. The person will just be repeating. You see, sometimes you be walking, you see a madman who will just be mentioning someone's name, and sometimes you think that, hey, that is the person that gave the person broken heart or something. No. Okay, those are all signs of schizophrenia, catatonic schizophrenia. So the person can be repeating one particular word, one particular sentence for a long time, or can be mentioning a particular name. The person will be mentioning the name, mentioning the name, mentioning the name for a long time. Okay, catatonic schizophrenia. That is what we call catatonic schizophrenia. So we have paranoid. If you say paranoid, the patient is going to experience delusions and hallucinations. If you say disorganized schizophrenia, disorganized, the person usually have disorganized speech. So for example, you are talking about something, you realize that what the person is saying it's not really in line with the topic you are discussing. Okay, the person is offbeat. Usually people say offbeat. The person is completely offbeat. Okay, and the person also have flat affect. No emotion. The person don't show emotion. So a good news come, you're expecting the person will be happy. The person will not be happy. A bad news come, you're expecting the person to respond as though the person is aware that there is a bad news. No sign of, emotions. Is that okay? Great. So that is all that are key signs of disorganized schizophrenia. Then we have catatonic. Catatonic, there is going to be motor rigidity, mutism, and echolalia. Motor rigidity, mutism, and echolalia. Okay. But then when we say undifferentiated or residual schizophrenia, that one, the person can have mixed. You can have someone who is having mixed, a mixture of disorganized and paranoid, meaning the person can be having delusions, hallucinations, disorganized behavior, disorganized speech, and flat affect. Okay, and such a person will classify the person under undifferentiated or residual schizophrenia. Undifferentiated or residual schizophrenia. Okay, what are the signs and symptoms of schizophrenia? Now, the signs and symptoms of schizophrenia, I usually classify them into 3. And that is how you have to do the classification to make the learning very easy. We have positive symptoms of schizophrenia. We have negative symptoms of schizophrenia, and we have other signs and symptoms. Now, the positive symptoms, we have delusions, hallucinations, and disorganized behavior. Now, listen. Anytime they ask you in exams, positive symptoms, these are what we call positive symptoms in psychiatry. Delusions, hallucinations, and disorganized behavior. Okay. Now, you can have a patient with depression who will have positive symptoms. In psychiatric nursing, listen carefully. Anytime you hear positive symptoms, we are talking about these 3: delusions, hallucinations, and disorganized behavior. Anytime you hear positive symptoms, we are talking about delusions, hallucinations, and disorganized behavior in psychiatric nurse. So if you tell you that the patient is having depression with positive symptoms, it means that patient is having depression with either delusion or hallucination or disorganized behavior. This is what we refer to as positive symptoms. So you are reading a psychiatric textbook, then you hear positive symptoms. You should remember positive symptoms, and the patient is having delusion. This is what represents positive symptoms in psychiatry: delusions and hallucinations, or how we call psychosis. In other words, you can say psychosis. The patient is having psychosis, then there is positive symptoms. Okay, psychosis also represents positive symptoms. And mostly if a patient is having psychosis, they can have delusions, they can have hallucinations, and disorganized behavior. Now, the negative symptoms include flat affect, apathy, okay, social withdrawal, and lack of motivation. Okay, that is what we call the negative symptoms. Okay, so when we say negative symptoms, we are talking about flat affect, apathy. Okay, apathy is like someone who do not have interest. They don't have interest in any activity. Someone who do not have interest, someone who lack interest, someone who is like the person is not motivated by anything. That is when we say the person is having apathy. Nothing motivates them, nothing interests them. Is that okay? That is apathy. So, and flat affect means lack of emotion, no emotion. The person don't show emotions. Okay, that is the flat affect. So we have flat affect, we have apathy, we have social withdrawal, and we have lack of motivation. Lack of motivation. Okay, this is what we refer to as negative symptoms. Okay, so keep it in your mind. Anytime in psychiatric nursing, any other condition, not only schizophrenia, you hear we using the word positive symptoms, then it means the patient is having psychosis, either delusions, hallucinations, or disorganized behavior. And negative symptoms in schizophrenia, we have flat affect, we have apathy, we have social withdrawal, and we have lack of motivation. Now, we can have other symptoms like cognitive impairment, poor concentration, disturbed sleep, or poor insight. Okay? So you see, because of the psychosis, because of this, the positive symptoms, the positive symptoms, because of the positive symptoms that we spoke about, the positive symptoms. Okay, because of the positive symptoms that we spoke about, that is why we give the patient antipsychotics. And that is antipsychotics like haloperidol or chlorpromazine. Okay, and we can even give second gen antipsychotics like risperidone or olanzapine. Okay, good. So because of the positive symptoms. Okay, so mostly patients with schizophrenia, we give them antipsychotic medications. Patients with schizophrenia. Okay, we give them antipsychotic medications. So kindly take note of that. Okay, antipsychotic med. And with regards to psychological or social care, we can do the CBT. Okay, cognitive behavioral therapy. We can do the family therapy, the social or occupational rehabilitation, and then community support. Okay, with regards to the nursing care, you have to ensure, because you see, patients with schizophrenia, they can either be risks of self-directed violence or others-directed violence. Self-directed violence means that they can harm their own self, or they can harm other people closer to them. Okay, so because of that, ensuring safety is one of the key things your care as a nurse should focus on when you are nursing patients with schizophrenia. You also have to build therapeutic communication or therapeutic and trusting relationship. You should administer and monitor medications. You should provide calm and structured environment. You have to reassure and reorient during hallucinations or delusions without confrontation. And you should educate patients and family on illnesses, medication adherence, and then relapse prevention. Okay, so that is schizophrenia. Okay, that is what we call schizophrenia. A chronic psychiatric disorder that involves disturbance in your thoughts, disturbance in perception, disturbance in one's emotions, behavior which impair daily activities or daily functioning. And I mentioned that the causes can be multifactorial. It can be genetic. It can be as a result of neurobiological. In fact, you not write the general paper without answering a question on schizophrenia. It's one of the commonest psychiatric conditions, which they usually ask questions on. Okay, so we can have paranoid. So if you tell you a patient is having paranoid schizophrenia, meaning that patient is experiencing delusions and hallucinations. If you tell a patient is experiencing catatonic, meaning that patient, if you assess, you are going to find motor rigidity, mutism, and echolalia. Okay. And I mentioned that the cardinal signs, we can have positive symptoms. In fact, for patients with schizophrenia, positive symptoms are conk. So positive symptoms, either delusions, hallucinations, or disorganized speech or behavior. The negative symptoms, we can have flat affect, apathy, social withdrawal, lack of motivation. Apathy is more like lack of interest. We can have other symptoms like cognitive impairment, poor concentration, and disturbed sleep or poor insight. Okay, so the medications I mentioned at the first line or the primary management is antipsychotics because of what? The positive symptoms. The antipsychotics. Now, the next condition we will be talking about is dementia. Dementia. Now, someone should read. Please, one of you should read for me, please.
Hello.
Yes.
Please, can I read?
Yes, go ahead. Okay, go ahead. I'm listening.
Dementia is a chronic progressive decline in memory, thinking, behavior, and ability to perform daily activities due to brain disease or damage.
Okay. All right. So what we are saying is that in dementia, okay. In dementia, there is a progressive decline in an individual's memory, behavior, and ability to perform daily activities because of a brain disease. Now, listen carefully. The underlying word over here is what? Due to brain disease or damage. Due to a brain disease or damage. So someone is having a decline in memory performance. How the person thinks, how the person even remembers things. Okay? How the person behaves, how the person performs daily activities because of what? Brain disease or damage. That is the underlying word. Listen. So dementia is as a result of what? Brain disease or damage. Now listen. In licensing exam general paper, mostly they are going to ask you questions on dementia and this condition, Alzheimer's disease. You know the focus. They want to see whether you understand the differences in what causes these conditions. Now, the signs and symptoms of these two conditions can be the same, but then the cause is different. Now, look at Alzheimer's disease, a progressive, irreversible neurodegenerative disorder that gradually destroys memory, thinking skills, behavior, and ability to perform daily activities. Now, look at this. You see, I've bolded it. The most common cause of dementia in older adults. The most common cause of dementia in older adults. Okay, so when we say Alzheimer's disease, we are looking at a progressive, irreversible neurodegenerative disorder that gradually destroys your memory. Okay, so with Alzheimer's disease, in fact, mostly Alzheimer's disease is as a result of aging. In fact, aging happens to be one of the serious risk factors of Alzheimer's disease. Now, someone can have a condition like vascular disease, like hypertension, like diabetes, like head injury, like smoking, and it can affect, the person's memory. Okay, it can end up destroying the memory. Now, look at the key word over here. Irreversible. Look, irreversible neurodegenerative disorder that gradually destroys. But look at how we said about dementia. A chronic progressive decline in memory. So the thing is that, see, over here, there is no structural problem. In dementia, There is no structural problem. That's what I want you to understand. But in Alzheimer's disease, something is destroying the memory itself. Okay, so we can have conditions like accumulation of amyloid plaques. Okay, we can have vascular diseases like head injury, like hypertension, like diabetes. Okay, smoking. All these conditions can cause Alzheimer's disease. Is that okay? You can have nerve cell damage. Okay, these conditions can all cause Alzheimer's disease. Okay, look at the cardinal sign of Alzheimer's disease: progressive memory loss, confusion, difficulty learning new information. Is that okay? And look at one key thing about the management of this condition. In terms of treatment, we have no cure. We focus on slowing the progression to relieve the symptom. Okay, but come and look at dementia. With dementia, unlike delirium, dementia develops gradually and is irreversible. Dementia is irreversible. Okay, so in dementia, there is a progressive decline in memory, progressive decline in thinking, progressive decline in behavior, inability to perform daily activities due to a brain disease or damage. That is the key word. There is a brain disease or damage. There is a structural damage to the brain. Okay, so in dementia, there is a structural damage in the brain. There can be a structural damage in the brain. Is that okay? That is what causes dementia. Okay, so when we talk of dementia, we are looking at a structural damage. So, for example, if someone suffers repeated stroke, there can be a physical damage to the brain that will cause dementia. But Alzheimer's disease is not like there is a structural damage. It's like there is a functional damage in the brain. There is a neurodegenerative. The brain is made up of neurons. It's like the neurons that are forming the brain, they are degenerating. There is a neurodegenerative disorder, okay, which gradually destroys, which affects how your brain ideally is supposed to function. Okay, so in Alzheimer's disease, it's not like, so that's why aging is a risk factor. We classify aging as one of the serious risk factors of Alzheimer's disease. So Alzheimer's disease, it's not like the person is having like the person has suffered a head injury or a trauma and it has damaged the brain tissue. In Alzheimer's disease, like the function of the brain, the physiological function of the brain has been impaired. That is Alzheimer's disease. But when we say dementia, there is a structural damage to the brain. That is the key difference. Okay, so in dementia, there is a structural damage. Okay, so someone has suffered repeated stroke and it has damaged the brain structure. Okay, so in dementia, there is a structural damage to the brain. That is dementia, a structural damage. Okay, a structural damage to the brain. Okay, understand the difference. But in Alzheimer's disease, there is a neurodegenerative disorder. It is not a structural damage. It's rather a functional impairment. Okay, a functional impairment in how the brain is supposed to function, probably because the neurons are degenerating. Okay, the neurons, they are losing their functions, they are degenerating. It's not like something has hit the brain and the brain structure has been affected, not like that. But when it comes to dementia, there is a physical or a structural damage in the brain. Note the difference, but their signs and symptoms are the same. Their treatment is the same. Please note the difference. Okay, so if someone can even be involved in a head injury, an accident, and suffer a head injury, the person will get dementia. That one is dementia. That one is not Alzheimer's disease. Okay, with Alzheimer's disease, for example, someone is growing and is losing brain function. One of the functions of the brain is to help you remember things. It's to help you make decision is to help you perform some task. For example, some of you know how to write. It's because of your brain is functioning normal. You see, someone can grow, the person will not be able to remember things to write. That is the Alzheimer's disease. So in this situation, the person didn't get an accident, and because of the accident, the brain has been affected, and therefore the person cannot perform certain skills. But here, the person is growing, and the brain is gradually losing its function, like by itself. There is no physical damage to the brain. That is the Alzheimer's disease. So Alzheimer's disease is more like someone losing the function of the brain gradually, but then we don't have any condition associated to it. That is Alzheimer's disease. Is that okay? Great. But sometimes, someone may lose brain function normally. There wouldn't be any structural damage, but it can be as a result of, let's say, a problem from another system. So, for example, maybe the brain is not getting enough blood supply. It could be there is no structural damage, but then the brain may not function well. For example, the brain is not getting enough sugar. It could be the brain has not been damaged yet, but the brain may not be able to function well. Is that okay? Good. That one is the Alzheimer's disease. Is that okay? So take note of it. So look at the causes. So see. But listen, remember that Alzheimer's disease too can cause dementia. Remember, Alzheimer's disease, it can be, so for example, neurodegenerative diseases like Alzheimer's diseases. Okay, neurodegenerative diseases like Alzheimer's diseases. It can cause, okay, so dementia is more like a patient who easily forget things, who have poor memory. The person will easily forget. So you tell the person, so probably even ask the person the name, the person wouldn't remember. Okay? You ask the person basic questions that the person was previously exposed to, the person wouldn't remember. That is dementia, meaning the brain function is going down. And one of the common causes of that is Alzheimer's disease. Someone can be involved in an accident and have a head injury and tend to forget things. Dementia. So when we say dementia, meaning you are losing your memory. You are losing your memory. Okay, you are losing how you previously used to think. Your ability to perform daily activities. You won't have that ability. That is dementia. Okay, and it can be due to brain disease like Alzheimer's disease. Alzheimer's disease is when someone is having like a degenerative brain disease. Okay, so the brain is degenerating, like the neurons, the nerves, they are degenerating. That is Alzheimer's disease. So Alzheimer's disease can cause dementia. When you say someone is having dementia, meaning the person easily forgets things. The person is unable to perform daily activities. The person is unable to remember, how things were even previously supposed to be done in a certain space. That is what we call dementia. Now, what are the cardinal signs of dementia? Memory loss. Okay, impaired reasoning or impaired judgment. Behavioral changes. We can have other signs like disorientation to time, place, and person. Difficulty communicating or finding words. Poor concentration and poor problem solving. Mood swings, agitation, hallucination in some types. Loss of ability to perform daily tasks. These are key signs of dementia. Okay, so anytime you hear dementia is when someone has lost the functions of the brain. Memory, the person is unable to think properly. The person easily forgets things. Okay, the person easily forgets. The person is unable to make judgment, make decisions. The person is unable to perform certain skills that previously they were able to perform. That person is having dementia. That is what we call dementia. Is that okay? That is what we refer to as dementia. Decline in memory, decline in thinking, decline in behavior, decline in ability to perform daily activities due to brain disease or damage. Is that okay? That is what we call dementia. So someone can get Alzheimer's disease. In Alzheimer's disease, the person is having a condition. Maybe when you are aging, your neurons can be degenerating. That is Alzheimer's disease. So someone can have Alzheimer's disease and end up getting dementia. You get Alzheimer's disease because of the Alzheimer's disease where your brain is degenerating physically or structurally. You end up getting dementia. Dementia is just, someone can even get a head injury and end up getting dementia. Someone can get stroke and end up getting dementia. Okay, someone can get a serious infection like HIV, syphilis, and end up getting dementia. Okay, and Alzheimer's, like I was telling you, Alzheimer's disease is a type of dementia. Okay, Alzheimer's disease, in fact, is the most common form of dementia. One of the commonest form of dementia. You get it? Good. So kindly keep it in your mind. So these two conditions, they are very close. Alzheimer's disease and dementia. In fact, the conditions do not have any cure. Usually we focus on the symptoms. When you are nursing a patient with dementia, you focus on the symptoms. But in terms of medications, we can give cholinesterase. Please pay attention to the medications very well. Please pay attention to the medications very well. Okay, pay attention to the medications. Cholinesterase inhibitors, especially if the dementia is as a result of Alzheimer's disease. We give cholinesterase inhibitors. Okay, we also have, if the patient is having moderate to severe dementia, we give memantine. We can even give antipsychotics or antidepressants if the patient experiences any psychotic symptoms like agitation, mood changes, and hallucinations. We can also have the non-pharmacological management. Now, the non-pharmacological management, we can have cognitive stimulation, memory aids, and occupational therapy. Okay. Apart from that, sometimes, we mentioned that if patient is having cardiovascular, we can have vascular causes. Someone who have been having repeated stroke. And hypertension is one of the serious risk factors for stroke. So management of cardiovascular risk factors is very good. Diabetes mellitus and BP, high blood pressure, all these two conditions can affect your vascular system and even lead to stroke. Okay, so if someone is having dementia and the person is having these conditions, pay attention and make sure you manage these conditions properly. Is that okay? Now, with the nursing management, maintain safety, prevent falls, because this person tends to forget things. Okay, sometimes you may even have to give them pen and paper. Sometimes you have to let them write things down so that when they forget, they can reference. Okay, and that is why you have to encourage independence in activities of daily living, but give assistance to patients when needed. You have to use clear, simple communication. Repeat instructions calmly. Okay, when you are telling or you are communicating to these patients, be clear, be simple, because see, if you come and talk plenty and use big words to these patients, they will forget. Use simple words, be clear, and be calm when you are communicating to patients with dementia. You have to monitor their nutrition. A patient with dementia is the patient that the patient have not eaten. You come, you ask, have you eaten? The patient will say yes, they've forgotten. They don't even remember. Okay, another time you come, have you eaten? The patient will say no, whilst they have eaten. Is that okay? Good. So you have to monitor nutrition, hydration, hygiene. You have to support caregivers or family with education and coping strategies. And you have to promote dignity and quality of life. Okay, this condition is just similar to Alzheimer's disease. So with Alzheimer's disease, there is a neurodegenerative disorder. Now listen, it's not all patients with dementia where there is a neurodegenerative disorder. You can have a patient with dementia. For example, someone can suffer, let's say, head injury, and the person will have dementia. That doesn't mean the brain, the neurons are degenerating. Okay, but Alzheimer's disease, The neurons are dying. They are being destroyed. There is a neurodegenerative. Look at the underlying word. There is a neurodegenerative disorder. This is the underlying word. Okay, but with dementia, it could be there is no neurodegenerative disorder. The focus with dementia is that with dementia, don't think about what causes it. The problem is that there is problem with memory, problem with thinking. So the person forget things. The person is having problem with thinking. The person is not able to reason. There is a problem with the person's behavior, and the person is unable to perform activities they were able to perform previously. Don't even think about thinking the cause when you are looking at dementia, because someone can have Alzheimer's disease and it can cause dementia. Okay, that's why we say Alzheimer's disease is one of the commonest causes of what? Dementia. Okay, that is fine. Good. So the medications are basically the same. The nursing management and interventions is also the same thing. Okay, because all of them, apart from the causes whereby the Alzheimer's disease is a neurodegenerative disorder, meaning the brain itself, the neurons are being impacted. Apart from that, the signs and symptoms, everything is the same. The management is the same, because all of them, at the end of the day, there is going to be a problem with memory, a problem with thinking, a problem with skill performance, with behavior, and ability to perform daily activities. So if you are nursing these patients, you have to assist the patient in the performance of daily activities. But then you should focus or encourage them to get involved in their daily activities. You have to encourage independence. Okay. Good. Now, let's move on to delusions. Delusions. Now, you remember that we mentioned that in psychiatry, when you hear positive symptoms, we are talking about delusions and hallucinations. Quickly, delusions and hallucinations should come into your mind. Positive symptoms or psychotic symptoms. Delusions. When we say delusions, delusion is when someone has a false fixed belief which is held firmly despite clear evidence that it is contrary. Okay, so you see, sometimes someone can have a false belief, a fixed belief. You can't convince the person, even though there is an evidence that what the person is thinking is false. That is what we call delusion. Okay, now a practical example is that someone having a belief that there is an illness in the stomach. Someone can tell you that my stomach is vibrating. Meanwhile, in reality, the stomach is not vibrating. Okay, meanwhile, in reality, it is not true. Okay, my stomach is vibrating. Meanwhile, in reality, it is not true. Is that okay? That is what we call delusions. Okay, so the person has a fixed belief in something. Meanwhile, in reality, it is not true. Okay, so someone having a fixed belief, okay, in something. Meanwhile, in reality, there is a clear evidence that it is false. It is contrary. Okay, and delusions are very common in schizophrenic patients, and sometimes patients with mood disorders, especially, the mood disorders. We mentioned that some of them can have positive symptoms or psychosis. Okay, even in dementia, some dementia patients can have delusions. Is that okay? Good. So we can have a patient who is having schizophrenia who would have delusions. We can have a patient with mood disorders like the bipolar disorders who would have delusions. Okay. We can have someone who is having dementia who would have delusions. Someone can suffer brain injury and it can affect the thinking pattern. The person will have delusions. Someone can suffer stroke and have delusions. Someone can abuse a drug and have delusions. Okay, so delusions, we have about 5 types of delusions. I'll talk about 5 types. If you happen to see any other type somewhere, that is fine. But basically, I'll talk about 5 types. The 5 types, we have persecutory delusions. We have grandiose delusions. We have somatic delusion. We have erotomanic delusion. And we have nihilistic delusion. Now, what do we mean by persecutory delusion? You know, sometimes someone can have a belief that people are planning evil for them. Okay, you can have someone who be there. The person will be thinking that someone is planning evil for them. Meanwhile, in reality, okay, there is no evidence that someone is planning evil for them. It's a form of delusion. Okay, so the person is thinking that people are somewhere planning evil. It's like they are planning against them. That is persecutory delusion. Believe that others are harming them or others are planning, they are conjuring against them. Meanwhile, it is not true. It is contrary. That is a persecutory delusion. We can have grandiose delusion. Grandiose delusion is like exaggerated self-importance. The person can make a statement like, the president of Ghana is my firstborn. Meanwhile, there is no evidence. It is contrary. Okay, that is what we call grandiosity. Grandiose delusion. Grandiose delusion. More like exaggerated self-importance. Okay, I'm the most intelligent person in Ghana. I'm the most intelligent person in the whole world. So if people make exaggerative statements, they are signs of delusion. They are signs of delusion. Exaggerated self-importance. Okay, grandiosity, grandiose delusion. We can have somatic delusion. Somatic, belief of illness or defect. You know, some people can be there and they can feel that it's as if something is in their stomach. Meanwhile, there is no evidence. Okay, the person can make a statement like, my stomach is not moving, or my stomach is moving. It's like the person has this belief that there is an illness somewhere in their body. Meanwhile, there is no evidence. It is contrary. Meanwhile, it is false. That is what we call somatic delusion. Usually, that one is associated with illness that is affecting any organ in the body. So if they give you any example in exams, they are giving you or emphasizing on an illness anywhere in any organ in the body. They are talking about somatic delusions. Then we have erotomanic delusion. Erotomanic delusion. Erotomanic delusion means that someone having a belief that someone loves them. Meanwhile, it is not true. You have a belief that someone loves you. Meanwhile, in reality, it is contrary. The person don't even know you. That is erotomanic delusion. Believe that someone loves them. We have nihilistic delusion. Okay, nihilistic delusion. Believe self or wealth does not exist. So the person can make statements that I don't exist in this world. Okay, there is no world. There is no human being. So we have people who believe that themselves or the world, they don't exist. The person can make statements like, I am an ancestor. Okay, so believe that yourself or the world does not exist. That is nihilistic delusion. So when we say persecutory delusion, when someone believes that others are planning against them, okay, they are planning to harm them, or they are planning to fight them, or planning to disgrace, or planning like, meanwhile, it's actually contrary. That is persecutory. Grandiose, exaggerative self-importance. The president of Ghana was my junior in class. Okay, like exaggerative statements. The president of Ghana is my firstborn. Meanwhile, in reality, it's contrary. It's completely false. Okay, that is what we call grandiose delusion. Okay, I feel my heart is not beating. I think my heart is no more. I think my heart is having a problem. Meanwhile, in reality, it is contrary. Is that okay? That is somatic delusion. Erotomanic delusion, believe that someone loves them. Meanwhile, in reality, it is not true. Okay, great. So that is delusion. So delusion is when someone has a false or fixed belief firmly, despite clear evidence that it is contrary, it is not true. They have belief. That is delusions. Okay, and remember, delusion is a positive symptom in psychiatry, or it's a psychotic symptom in psychiatry. Then we have hallucinations. Now, hallucination has a relationship with sensory information. Sensory. You know our sensory. We have the auditory sense. We have the visual sense. We have the olfactory sense that we use to smell. We have the gustatory sense that we use to taste. And we have the tactile sense that we use to feel. Okay. Hallucination is related to sensory system or sensory organs. Now, when we say hallucination, there is a false sensory perception. You are perceiving something with any of the sense organs, which is false. That is what we call hallucination. You are perceiving something with any of your sense organs, which is false. Now, if you really want to understand hallucination, you should relate it to sense organs so that you'll be able to differentiate it from delusion. Delusion is about belief. It's not about sense. It's not about any of your sense organs. It's about your belief system. So with delusion, you are not believing with your sense. You are believing with your thoughts. You get it? With your thinking, with your perception. But with hallucination, it's a perception that you are making using your sense organs. So for example, if, for example, you tell us that, okay, you are hearing people mentioning your name. Meanwhile, in reality, nobody is mentioning your name. So when we say hallucination is like a false sensory perception, experience without external stimuli. Okay, it is experience without external stimuli. So someone tells us that, oh, I hear people telling me they are coming. Meanwhile, we are there with the person, we are not hearing anything. Oh, I hear two boys shouting. Meanwhile, in reality, we are there. We are not hearing anybody shouting. And that is auditory hallucination. We can have visual hallucination. In fact, with all the hallucinations, we have about 5 types of hallucinations. We have auditory hallucination, we have visual hallucination, we have olfactory hallucination, we have gustatory hallucination, and we have tactile hallucination. With all the types of hallucinations, the commonest is the auditory. Please keep it in your mind. With all the types of hallucinations, the commonest type is the auditory hallucination, where you are hearing voices. Okay, so someone can also say that, okay, someone can tell you, I see people fighting in front of me. Meanwhile, in reality, nobody is fighting. There is no stimuli. That means that in reality, what they are telling us they are seeing or hearing is not there. Okay, do you know we can even have olfactory hallucination? There are some people, they can be there, suddenly they smell something. Meanwhile, in reality, nobody has cooked. There is no food around, but they are smelling something delicious. That is olfactory hallucination. Okay, we can have gustatory hallucination. You know, some people can be there, they can taste things in their mouth. They can taste it. Meanwhile, in reality, okay, they can taste things in their mouth. Meanwhile, in reality, there is nothing like that. Gustatory hallucination. Gustatory hallucination. We can also have tactile hallucination. Tactile hallucination. Okay, feeling touched or crawling sensations. Tactile hallucinations. Tactile hallucinations. Okay, tactile hallucinations. Okay, so someone can be there and can make a statement like, hey, who touched me? Meanwhile, in reality, there was no stimuli. Nobody touched them in reality, in actual sense. Nobody touched them. That is tactile hallucination. Is that okay? Gustatory hallucination. Taste. The person feels the taste of a certain food in the mouth. Meanwhile, in reality, the person is not eating, or nobody is even having a food around. Gustatory hallucination. Olfactory hallucination. The person smells. The person smells the aroma of something around. Okay? It could be food. It could be, maybe it could be a pollutant. It could be a chemical. It could be anything. Meanwhile, in reality, there is nothing like that around in the vicinity. That is olfactory hallucination. Someone can also be seeing things that in reality, they are not there. So the difference is that in hallucination, you use your sense organs. But in delusions, it's a belief. Delusion is a perception from your memory. But in hallucination, you are perceiving something false with your sense organ. Either your ear, either your eye, either your nose, or your tongue, or even your skin. Okay, that's the difference. So hallucination has got to do with you perceiving something with your sense organs falsely. That is hallucination. Okay, now with the signs and symptoms of hallucination, we have cardinal signs. The cardinal signs of hallucination: persistence of non-existent stimuli. Now, one of the key ways you can identify something as hallucination is that in reality, there is nothing there. The person is telling you, I can see people playing football. Meanwhile, in reality, there is not even a TV. Nobody is playing football too. So that will tell you that this is a visual hallucination. Is that okay? And mostly, hallucination is also a psychotic symptom. So mostly, if a patient is having hallucination, we give them antipsychotics, like the haloperidol. You remember we mentioned that delusion is also a psychotic symptom. So if patient is having delusion, we give them antipsychotics, like the risperidone, olanzapine, haloperidol. The same thing applies to hallucination. We give them antipsychotics, like the haloperidol, risperidone, olanzapine, to treat the underlying cause. It could be as a result of alcohol withdrawal, or it could be as a result of infections. Okay, hallucinations, a false sensory. So hallucination has got to do with you perceiving something false with any of your sense organs. That is the easiest way to understand. But with delusion, you are not using sense organs. You are using your brain to perceive, your mind to perceive something false. So that's why we say delusion is a false or fixed belief held firmly despite clear evidence to the contrary. Okay, so with delusion, you don't use sense organs. But with hallucination, it's a sensory perception. We use the sense organs, the sensory perception. The auditory is perceiving something false. The visuals are perceiving something false. In reality, they are not there. Okay, that is what we call hallucinations. Okay, good. Now I think I'll end over here. Yes, I'll end over here. The next thing that we will be looking at,